We ready? Are you ready? Okay. I can start? Great. Good morning. I'd like to call this hearing to order. Today is Thursday, February 9th, 2023. The time is 9:30 a.m. We are meeting, well, I'm in room 412 of the John A. Wilson building, and we're also meeting via the Zoom internet platform. This meeting is also being broadcast live on cable channel 12 and on my YouTube page at CMC Henderson. I am at-large Christina Henderson, chairperson of the Committee on Health. Today, we will hear testimony from the public witnesses, as well as Anjal Jacobs, chair of the UMC Fiscal Management Board, and Jacqueline Payne-Borden, the UMC Chief Executive Officer and the Chief Nursing Officer. The not-for-profit hospital corporation, commonly known as United Medical Center, or UMC, is a district government hospital serving Southeast DC and surrounding Maryland communities. UMC is an independent district instrumentality created by legislation adopted by the DC Council in 2010. It provides inpatient, outpatient, psychiatric, and emergency care. UMC is governed by a fiscal management board, which serves as a control board and is led by Anjal Jacobs as the designee of the Office of the Chief Financial Officer for the District of Columbia. UMC will close once the new Cedar Hill Regional Medical Center opens at St. Elizabeth East Campus in Ward 8. The committee sent written pre-hearing questions to UMC, and we will reference those materials throughout today. If anyone is watching who'd like to see the materials, they can be found online on the council website at dccouncil.gov. I do see one of my colleagues here, Councilmember Zachary Parker from Ward 5. If you'd like an opening statement, I ask that you keep it to 5 minutes or less. Thank you.
Thank you, Chair Henderson. I will keep it even more brief. I'm looking forward to the testimony today and following up with the respective agencies. Thank you.
Oh, that was brief. Okay. We will now hear testimony from public witnesses. We only have 2 this morning. I'd first like to review the testimony guidelines. Witnesses representing an organization will have 5 minutes to speak, and witnesses testifying on their own behalf will have 3 minutes. We have a clock that will be counting you down as you begin speaking, and I will give you a nudge when your time has expired, as I have another hearing later on this afternoon. For anyone who is not able to attend or speak today, we will accept public written testimony until February 23rd, and I'll provide those instructions at the end of this hearing. I'll now call the first panel of witnesses. Please accept the invitation to be promoted from attendee to panelists. William Long and Janet Phoenix. Okay, neither of the public witnesses seem to be here, so we will go straight to our government witnesses. Anjal Jacobs, Jacqueline Borden-Payne, and Lillian Chukuma. I'm sorry, Miss Lillian, you have to.
You got it perfectly right, man.
Oh, did I? Okay, I was like, you're gonna have to tell me how to say it again. Miss Jacobs, is everyone presenting testimony or just you? Oh, maybe they didn't think we were going to start on time. Hold on one second.
I'm sorry, I'm talking to you on mute. I'm sorry, I'm here.
Okay.
I apologize.
No problem. We can't see you.
Hang on, I'm trying to now. Can you see me now?
Yes, we can see you now. You can go ahead.
I apologize. We cannot, however, I cannot see you, but I can hear you very well.
Okay. Hang on one second. Okay, just have her testify.
While we troubleshoot, how are you all this morning?
We're doing very well. Thank you,
Good,
Councilmember.
good.
How are you?
I'm doing well. Thank you all for being patient with us.
No problem.
No problem. Thank you.
Nice to meet you too.
Likewise. Likewise.
Ms. Jacobs, while so it seems you all can be seen, I can't be seen, but I don't need to be seen in order for you to do your testimony. So why don't you go ahead and then as they troubleshoot.
All right. I'd be happy to do that. Good morning, Chairperson Henderson and members of the Committee on Health. I'm Angel Jacobs, Chair of the Fiscal Management Board of the Not-for-Profit Hospital Corporation, more commonly known as the United Medical Center, or UMC. I also serve as the Deputy Chief Financial Officer and Chief of Staff for the Office of the Chief Financial Officer. I'm pleased to appear before you today, along with UMC CEO, Dr. Jacqueline Payne Warden, and CFO Lillian Chakuma, to discuss the fiscal year 2022 and fiscal year 2023 performance to date of UMC. Despite many challenges in fiscal year 2022, I'm very pleased to report that UMC continues to fulfill its mission of providing quality medical care to our residents. On the financial front, UMC ended the year with a balanced budget and received an unmodified or clean opinion from the independent auditors on its financial statements, with no material weaknesses, significant deficiencies, or audit recommendations. This is quite an accomplishment for UMC, and I'd like to take this opportunity to congratulate and thank all staff that support UMC on these stellar accomplishments. When we last appeared before the committee, the hospital's daily operations were overseen by the management firm Mazars Incorporated. In July of 2022, the Fiscal Management Board decided not to exercise future option years of the Mazars contract and to instead entrust the daily management of UMC to the very skilled and capable in-house executive management team led by Dr. Payne Warden. The board has every confidence that this leadership team will ensure continued quality care to our patients, engage with partners and stakeholders to serve the community, and act as good stewards of our available resources until the hospital's closure. As you may recall, last year we reported a severe nursing shortage at UMC, which resulted in significant rates of ambulance diversion. The problem of diversion due to lack of staffing has largely been resolved due to the new nursing leadership, which has continued to effectively recruit new nurses while better managing nurse scheduling and effectively using agency nursing resources to ensure proper clinical coverage. While we celebrate this success, we acknowledge that fiscal year 2023 has also brought challenges to UMC. We continue to see declines in actual patient activity compared to budgeted activity. In addition, as of the end of the first quarter of fiscal year 2023, the hospital's disproportionate share hospital payment, known as DISH, was further reduced from fiscal year 2022 levels. This reduction has created budgetary challenges for the hospital. In response, the UMC management team is taking action to review internal utilization, increase operating efficiency, and control costs where possible, with the full expectation that the hospital will end the year in balance. I would like to turn now to our CEO, Dr. Jacqueline Payne Borden, who will provide greater detail regarding the hospital's performance, after which we would be pleased to answer any questions the committee may have. Dr. Borden.
Thank you. Good morning, Chair Henderson. Congratulations on your new role, and good morning to the other members of the Committee on Health.
Good
My
morning.
name is Jacqueline Payne Borden, and I have the privilege of serving as the Chief Executive Officer for the Not-for-Profit Hospital Corporation, commonly known as United Medical Center. I am honored to have joined the UMC family in 2018 as a Chief Nursing Officer, and even more honored and humbled to be serving in the capacity of CEO. I will provide testimony on behalf of the dedicated and resilient staff who, despite change and challenges, continue to put the welfare and health of the residents of Ward 7 and 8 as paramount. We strive to consistently provide high-quality, evidence-based care at UMC. This past year was monumental for UMC. During the last quarter of fiscal year 22, under the direction of the Fiscal Management Board, the decision was made for UMC to function and operate without an external operator. This decision was met with enthusiasm by the internal leaders and staff who were ready and willing to continue supporting the hospital and the larger community as one cohesive team. I am confident the operations of UMC will be successful until such time as Cedar Hill Regional Medical Center opens its doors to our community. The following is my testimony on fiscal year 22 and 23 to date. Madam Chair, in spite of the planned future closure of UMC, we continue to operate at levels to meet or exceed the standard of care for an acute care hospital. We have a level 3 emergency department and the following inpatient units: behavioral health, med-surg telemetry, dialysis, critical care or surgical services, and allied health services. Working alongside our emergency department staff are peer recovery coaches who provide non-clinical support such as peer support, motivation, and referral and links to external services for the treatment of alcohol and substance use issues, as UMC does not have a licensed substance use or detox program. However, UMC is actively involved in the fight against opioid-related drug deaths. We distribute Narcan kits to at-risk patients who present in our emergency department. Our Department of Pharmacy continues to participate and work in collaboration with Ward 8 Communities Opioid Solutions Working Group Health Alliance Network. The Behavioral Health Unit continues to accept patients in both voluntary and involuntary status, and partners with the Department of Behavioral Health and core agencies, service agencies, to provide inpatient psychiatric services. Patient safety and quality are the cornerstone of delivering quality essential health services. Over the past year, this has been challenging for many healthcare systems, including UMC, and there was a slight increase in the incidence of COVID-19 during the fall of 22 and the threat of both Mpox and Ebola. Regardless of the challenges, UMC maintained a safe environment for patients, staff, and visitors. UMC stayed engaged with DC Health, DC Hospital Association, the CDC for current, relevant, local, and national statistics and recommendations to promote and sustain safety and quality within our hospital. UMC's quality, process improvement, and infection prevention and control teams continues to remain laser focused. Our infection control performance remains above the national standard, with 1 central line associated bloodstream infection, 0 catheter associated urinary tract infections, and 0 ventilator associated events. Additionally, we had outstandingly low rates of hospital acquired infections, such as VRE, which is vancomycin-resistant enterococci, and MSRA, methicillin-resistant Staphylococcus aureus, and surgical site infections. These results are evidence to support the quality care we provide. From a regulatory and certification perspective, UMC renewed and received its annual certification from DC Health Regulation and Licensing Administration. Our lab had 2 surveys and was reaccredited for the next 2 years by the College of American Pathologists and American Association of Blood Banks. The pharmacy renewed certification for the intravenous IV room without issues. Radiology department was successful with annual inspections for mammography and Nuclear Regulatory Commission. UNC is currently in the window for our triennial Joint Commission survey. In terms of staffing, the national and global shortage of healthcare workers has been challenging throughout all phases of the COVID-19 pandemic. UMC is therefore not unique with staffing challenges. However, UMC's staffing challenges predated the pandemic with the announcement of the hospital's planned closure, which was compounded by the effects of the pandemic. During the fourth quarter of 22, there were improvements in nurse staffing in our ED, ICU, med-surg telemetry units. The labor contract budget was significantly increased from 3.5 to 7.8 million to address staff shortages. UMC continues to actively recruit for critical vacancies while using contract labor as necessary to support clinical operations. In conjunction with recruitment, the hospital recently went live with a new human resources system, a software that, in addition to other functions, promotes process improvement with the recruitment and hiring process timeline. This same system, when fully implemented, will support efficiency in various HR functions, including managing and tracking performance evaluations. Madam Chair, the hospital has an aging infrastructure that must be maintained. Throughout fiscal 22 and 23, preventative maintenance and repairs on generators, cooling towers, chillers, and elevator systems are being accomplished and ongoing, allowing us to operate the hospital in a safe way while meeting regulatory compliance. We are grateful for the collaboration with district agencies that continue to provide their expert guidance to aid us meeting various regulatory mandates. Contracts and procurements are the bedrock of our operations. UMC has made it a priority to improve our internal contracting and procurement process while abiding by Title 27 of the DC regulations. Our primary goal is to avoid or reduce the submission of retroactive contracts to the City Council. We have taken various steps, such as enhanced training and contracts review, to focus on this goal. We will accomplish the aforementioned within the parameters of our budget, being strategic in managing costs through greater accountability while not compromising high quality care that our patients deserve, and equally important, providing an optimal work environment for our deserving staff. In closing, I would like to thank you, Chair Henderson, and members of this committee for the opportunity to testify on behalf of UMC. We endeavor to maintain a high standard of unbiased patient-centered care for the residents of Ward 7 and 8 and all who enter our doors. UMC staff will remain flexible in both our thinking and our actions, and appreciate the support of the Committee on Health and other stakeholders as we encourage and support the committed staff of UMC. It is an honor to be on the team who will care for the hospital while Cedar Hill Regional Medical Center is being completed. We are proud to be UMC running UMC. This concludes my testimony. Thank you.
Thank you. Can you see me and hear me now?
Yeah.
Yes,
Great.
ma'am.
So we were joined by a public witness while Ms. Jacobs was presenting her testimony. If it's okay with you all, we'll take his testimony and then we'll begin with questions from council members. So Mr. Long, if you could just accept our invitation to be promoted. Mr. Long, if you could hear me, in order for you to be able to present your testimony, you have to accept the invitation to be promoted to a panelist. So I see you in the attendee room, but we can't manually move you. There we go. All right, Mr. Long, if you're speaking now, you're on mute. So unmute yourself. You're still muted. Okay, Mr. Long, we've also prompted you to unmute. So if you just hit that button to say unmute.
I'm trying.
Oh, we can hear you now. We can hear you. Go ahead, Mr. Long. Mr. Long, are you still with us?
Yes.
Okay, it's your turn. You can go ahead and present your testimony.
Okay. Good morning, ladies. My name is William Long, and gentlemen. I have my concerns with the health and the hospitals is the neglect on parts of particularly people who are less fortunate, who cannot be able to I guess just simple as this. Clinics, I even talked to the director over at Bread for the City, and they turn a lot of people away. They give funding to
Mr. Long, we lost you again.
just these people, just the medical, the hospitals here in the district. I feel that that they could better serve as far as the people here, particularly the less fortunate, the homeless people, such as
Mr. Long, you're going in and out. The last thing we heard is you feel like the hospitals in the district can better serve residents.
That's primarily my concern. That how about if you're gonna populate the city? How about particularly homeless places, subsidized living, more hospitals? If you're gonna have more people in the city, basically that's my concern. And again, I talked to the director. He called me back. And they're turning people away at these clinics. You know what I'm saying? I just supposed to have filled in for like even DC General when it was gone. You got Unity Clinic and other clinics, which refer you to a hospital. You know what I'm saying? And I think that, a little bit more need to be done. Need to dig deep in the pocket of the federal government to get these hospitals and these subsidized living a little more. If you don't get rid of stuff, then you're supposed to replace it. Subsidized living, particularly in hospitals and stuff like that, because they're overwhelmed, this pandemic and all this other stuff where you need more services, but you're getting less service to me. Particularly, like I say, I've been hand and foot with various organizations while they serve.
Mr. Long, are you still going?
in this issue. It's sad that the nation's capital has got homelessness and these other problems.
Mr. Long, you're going in and out, but I think we heard the gist of what you were trying to get across. So I thank you for taking the time to provide testimony, even with the technical difficulties that we're having today.
Serve, our public, people who are in need of health care, and even homelessness. And, just put back and take down, make the stuff ready and available for people. Both, especially people who are less fortunate, mentally challenged people, ones who are depressed and stressed and drug addicts, that's escaping from reality and can't deal with these issues. They're too overwhelming for them. So I guess they resort to drugs. I've seen so much. And I don't know weary your time, but this is what I can just say off the cuff. And I hope that you all can get together and do make a difference in this city and make better services for our public and for people particularly who are less fortunate, homeless, helpless people who are mentally challenged, people who are ignorant, not as intelligent as you all. You know what I mean? And so it's people out here, we have to think and help them and understand them. Mental services, oh my God, so many people are challenged, but they dealing with psychiatric drugs. Then we had that.
Thank you, Mr. Long. Thank you for your testimony today. Okay, I think we are gonna go on to questions now. Councilmember Parker, we'll do 15-minute rounds so that hopefully will allow you to get a good chunk in. All right, so let's get to it. Okay. I'm not entirely sure who answers what, so I'm just gonna ask the questions and you all can sort of decide amongst yourself. But actually, before I begin, we have a new rule that all the witnesses have to be sworn in. So if you could raise your right hand in the view of your camera, great. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is truth, the whole truth, and nothing but the truth?
Yes,
I do.
Gotta hear everybody. If you just take yourself off mute.
I do.
I do.
Okay, so let's start with organizational. In your pre-hearing responses to the committee, you stated for FY22 that there were no performance evaluations under the previous hospital operator, Mazars. How is UMC changing this practice at the hospital, and how will it ensure that employees have evaluations going forward?
Yes, may I take that question? When Mazars was here, they did have evaluations, but it was not consistently accomplished. They were not consistently accomplished. With this new leadership team, it has been emphasized that this must be done, and we have the leaders ensuring that they complete the evaluations and whoever reports to them so the staff could be evaluated, which includes a goal between now and the next evaluation period. In addition, we have this new software, which when it's fully deployed, all the parts are working. This will help us with evaluation tracking as well, monitoring evaluations. It will be
Are all of the positions, okay, were all of the positions that were formerly held by Mazars employees now filled by UMC employees?
Yes, yes, ma'am.
Okay. And Ms. Payne-Borden, you were the chief nursing officer prior to, did you backfill that position? Or are you wearing both hats?
I'm wearing both hats.
Okay, is that an intent? Do we intend to continue that long term?
Yes, for now, yes, ma'am. We intend to do it long term.
Okay. You know, we have a lot of people in district government who wear multiple hats, and so I worry about them in terms of, you know, running the whole hospital and also being the chief nursing officer seems like two very full-time jobs. And so I just want to make sure, so you do plan to continue, you're not doing a search now for someone to take over that position?
We do plan to continue. However, I do have a VP, a vice president of nursing services.
Okay.
And a senior director of nursing.
Okay.
So I have good help.
Okay. What was the cost savings associated with the termination of the Mazars contract?
Ms. Chakuma?
Good to see you again, Council Chairwoman. The savings for the contract we had with Mazar was it started with a 7 million, then came to 6.2. So on their exit, we spent about $1.1 million trying to restructure and do certain things. And so you see, we saved about $5 million with their exit. However, it's not any savings that is stashed away. You know, our challenges are many, and it has helped us in so many other things that we wouldn't have known how to settle those costs. Okay.
That's good to know. And just for the record, I
apologize, Chairperson.
No, you're totally fine. Just for the record though, because we are talking as though it is general knowledge that Mazars is no longer running UMC. And I don't know if the public knows that. In terms of, so how long has the Mazars contract been terminated? This is just for the record.
So the contract terminated in July of last year. And so since that time, the hospital has been run by our in-house executive leadership team.
All right. Ms. Jacobs, do you currently have a full board? In other words, there are no vacancies?
We have one vacancy on the board. So we have a total of 6 of the 7 are filled.
Okay, and do you know what the plan is for filling that 6th position?
I do not, but I can certainly get an update. But despite the vacancy, I'd like to say that the board functions extremely well and is very committed to making sure, all of its members are very committed to making sure that the hospital's oversight is consistent and that we support the executive leadership team effectively.
Great. All right, I want to talk a couple of budgetary questions. Ms. Jacobs, you mentioned in your testimony about the DISH payment reducing, DISH disproportionate share hospital payment. How much has it been reduced by?
So I'm going to turn to our CFO to give the exact numbers on what the reduction was from fiscal year 22 until now.
Okay.
Approximately $4 million.
You said approximately 4 million?
Yes.
Okay. And what drives that reduction?
Multiple things in the DISH calculation. You have activity plays a role and some policy changes with Medicaid or some methodology comes to play because we have what is included, what is not included. So it's a lot of things that go into it, but activity is one of them. And then with some policy changes. And I could, of course, meet with you to get into detail. It's a little more complicated.
Okay, but when you say policy changes, is that policy changes from you all or policy changes from DC Healthcare Finance?
From DC Healthcare Finance or CMS, okay. Different things, yes.
And when they made the decision to make the reduction, because I think for a hospital like yours, a $4 million reduction is significant in terms of the financial operations of the hospital. So I'm curious if there was a conversation that was had to help you all better understand what was happening, but also what, if anything, UMC can do to get the money back, essentially.
As you know, DISH is not just hospital specific. It is a lot other hospitals that that
Right,
qualify
right.
for DISH. So it's not a decision they make one hospital or another. So when decisions are made or policy changes happen, like what's supposed to be included, whether we should include crossovers, whether we should include private insurance payers. So it's not just for us. So they do tell us, yes, they notify us, they tell us what's going to happen. And of course, there's a DISH tool that they give us to gather information so that everybody will be able to populate and put their information out there. And they're able to tell us to say, oh yeah, you're going to have changes. But by the time we do, you could see, we're about to come in a month for our budget hearing, but in a month for our budget hearing. At that point, we've already finished our budget. By the time we do the DISH tool, we're not going to be able to change it in the budget process. So yes, they do tell us.
Okay. I'm just curious I have healthcare finance before us next week. And so, as you said, it's not just UMC, it's all of the hospitals who are sort of facing this situation. But usually when we do policy changes in general as a government, there's a particular notice period that allows for adjustment. So whether it be they tell you 30 days in advance, they tell you 60 days in advance, I'm just trying to get a determination of how much notice you all received.
Well, I just want to make sure I'm using the right word too. When I say policy changes, it's the decision. They are public notices. These are information that the judge don't get up and make the decision and implement, because they do notify, the DC hospitals, different places participate. The deputy mayor comes, gives us presentation, tells us what's going on and all that. So it's not anything that people are taking unawares when these processes happen. And sometimes CMS federal decisions also come into it. So I'm sure it has never failed over the years for public involvement and hospital involvement to be in all these decisions. But when it's all said and done, they will do what is best for the district or for the agency.
Okay. In the pre-hearing questions you submitted to the committee, UMC reported having a $2.2 million surplus in FY22 and projecting a $130,000 surplus in FY23. First, does surplus mean surplus? Because I've learned from past conversations with you that our definitions aren't always the same.
Surplus means that our revenue exceeded our expenses. Yes.
Okay. So I guess what you're projecting for let me back up. For the $2.2 million surplus in FY22, was that, I'm assuming those finances were able to roll over to FY23 to help plug any gaps that you might have?
As you may know, our challenges come day by day, but definitely because we ended September, the very first day of October, there are things to be paid. Yes, it definitely comes over for us to be utilized before I get my subsidy even. Yes, it was.
Okay. So this is kind of an unfair question because I'll see you guys in like 2 months for the budget hearing, but does UMC expect that it will need to request anything on top of the $15 million in local subsidy that you already received?
Not from where we sit right now. We have projected that we will balance the budget, but again, we have a hospital to run as we go day by day. You don't know what happens. Some of them are beyond our control. We never know. Just like a couple of years ago, the COVID showed up, so you don't know what comes. So for right now, we're projecting to have that break even. That 130 is basically a break even year.
Yep. Okay. In the pre-hearing questions, you all reported that UMC spent about $7.2 million on contract nurses in FY22 and $2.9 million Q1 of FY23. So on track already to spend significantly more on contract nurses this fiscal year than last. Obviously, I think both of everyone mentioned in their testimony, and we know there's a national nursing shortage, but I'm curious what you all are doing or trying to do in terms of decreasing the cost of contract nurses and the overall reliance on contract nurses.
From where I sit, the CEO might have some other things to add. We don't really expect the decrease in contract nurses. I'm telling you the truth, because the hospital is closing. We want to make sure that patients receive the care they need. That is why, if you listen, as she reflected in her testimony, that we have increased it. When it came to you for the council sign off, it was huge. It's the highest we have increase in our contract labor, because we want them to be able to still see patients and not be worried about the cost. Because remember, the key here is, when we don't have the staffing, we move it to contract labor. Cost of nursing is expensive. So when you really compare it now to contract nursing, we just in the same place. If we find the vacancies, people to fill them, we're glad. But if we don't, definitely the contract labor, I don't expect them to be in the decrease. But they will continue to use them as necessary. And believe me, they are managing it the way they're supposed to. And I think it's the right way for us to continue to do, to support them, give them enough contract labor so that we have no problems with diversions or different things that might come because we don't have enough staffing.
Well, so Ms. Payne-Borden, I guess from a trend perspective, or even in the conversations that you're having with the CEOs of other hospitals, this new reliance on travel nurses or contract nurses, do we feel like this is now a new reality in healthcare, or that we'll eventually see more individuals who will try to sign on, a more permanent contract?
For right now, Madam Chair, it's a new reality. Healthcare is changing due to the pandemic, so it's national.
Okay. I'm looking at the numbers. I'm trying to be mindful of if I can actually get a question off. Ms. Jacobs, in your testimony, you mentioned a continued decline in patient activity compared to budget activity. What is causing this continued decline in patient activity? Is it just the overall reality of individuals knowing that the hospital is closing, or is something else going on here?
So thank you for the question. I think it is. I think the major driver is the reality that UMC is closing. And so patients are finding new healthcare relationships as they know that the hospital will be sunsetting in the near term. And so that is a major driver. But we continue, to fully staff and serve the patients that do come through our doors. But everyone knows that the life of UMC is a short one at this point.
Okay. I don't have enough time to get off another question. So Councilmember Parker, if 15 minutes.
Thank you, Chair Henderson, and thank you all for your testimony. I want to pick up on the conversation that was just being had, the reduction in the dish, I believe I'm using that term properly, was being described as a decline in activity. And you were just speaking to fewer people visiting UMC. Can you just give more specificity to the numbers and the level of decline that you're seeing?
Okay, thank you. And thank you for the question. I'll tell you, I've been here now 9 years. This is my 9th year. And when I arrived, we had 60,000 ED visits. Now we are barely hitting 35.
To what extent does that speak to the $4 million, I believe, decline that you're seeing versus the policy changes that you were speaking to earlier?
Well, I will have to go into the detail of all the calculations to factor which piece was activity, which piece was due to, because we have now crossover, again, I'm willing to come and meet with anybody so that we could go through the processes, because this calculation is a little bit more complicated. Yet we based on our uncompensated care, those things that we don't get reimbursed, because it's for hospitals that are disproportionately served, that we did get that advantage to, they don't pay us as they come in, but we have that opportunity to utilize the number of what we are not paid to factor into what we get from that dish payment. So now some policies, if I'm using the right word, because Deputy Mayor, I hope he's listening, I'm making sure that I'm using the right word. We have what we call crossover. We have insurances, the kind of things that will no longer, that used to be included in the calculations that are no longer now allowed. So before, it was like a kitchen sink. We could use everybody,
Yes.
Medicaid to put in the.
So it seems like it's a perfect storm of scenarios that is speaking to
Different scenarios go into what makes up. So that 4 million is still a major part of it. Will be activity driven, because the less, if I have a better admission, a better population, different kind of population, maybe that crossover will not affect me. But those things, the activity is really the driving force. But
I understand.
Yeah.
So as a follow-up, I would request that you share. Am I frozen again?
Lillian.
Okay, I'm not frozen. I'm sorry. I'm just getting you're freezing on my end. So my apologies about that. But if you could just follow up with a detailed breakdown that speaks to that $4 million decline, and to what extent does that relate to a decline in activity, to reimbursements, to policy changes, that would be helpful. Okay.
All right. It will all come to it, but yes, I will provide that to you.
Thank you. On a related note, you talked about greater efficiencies. Because of this decline, you've had to look to greater efficiencies. Can you speak more to what you meant by that in your testimony?
Angela, you take.
Yes,
I'll
Ms.
start.
Jacobs, sorry.
No problem. Yeah, so the executive leadership team is looking at initiatives in the hospital, ways to eliminate waste, ways to repurpose, and to make sure that we are maximizing every available resource so that we can provide savings to cover any shortfalls that we might have because of a loss of dish. Ms. Chikuma, do you want to add a little more?
Yeah, I can imagine what efficiencies mean, but I'm getting at what are some of those efficiencies that you've looked to make up for the $4 million decline?
Okay, thank you again for the question. As you heard in the testimony, UMC, running UMC, over the years, since I've been here, external operators have run the hospital. So a lot more removed from those people that were doing the work, really, that could make the change, were not a part of participating. Now they are touching it, whether it's in overtime, we are keeping our hands on it, whether it is in contract labor, which she mentioned earlier. We are, yes, making a big budget for contract labor, but we want to make sure that we're not using contract labor, we're using overtime, and then we're using, and salaries are going up, because there were situations where increases were given, then people work overtime, we're still using the agency, different things that, that were running away before and now being monitored. We are looking into supplies, making sure that things are aligning with the activity level. It wasn't just buy whatever is out there that we think we could buy. We're now making sure that we need it and the activity level supports it. So different things that we are looking for, those efficiencies that will create the opportunity to close the gap.
Is it fair to say, and what I think I'm hearing you say, is you're being more judicious with the contracts that you're establishing?
I think so, yes.
Absolutely.
Okay. So that is good to hear. I have some other questions around the staffing shortages, but I will come back to that. I wanted to pick up on two different threads. So you talked at length about your diabetes program, and a number that stood out to me is that you said 40% of patients that are coming in are part of this either inpatient or outpatient program, receiving some type of care or educational support around diabetes. And specifically the question in the pre-hearing questions was asking about the number of patients that you're serving and getting to success rate, but I didn't see that in your response. Can you just speak to specific numbers of patients coming in, receiving care, and to what specificity? And I understand you may not have that off the top of your head, but if not, I would like for you all to follow up, just given that a significant portion of your patients are coming in needing care around diabetes.
Yes, yes, Sir Parker.
Yes.
I will
yes.
make sure we have that overall number to provide later on.
Yeah, so two things. One, the number, but also how you're determining success. And so I saw in your statement, you spoke to success in administering insulin, which is great, but I would imagine success means people surviving, thriving, living.
Yes.
And that what did not come through clear. So
Okay, I apologize for that. I will make sure that you get that information.
awesome. In preparation for this hearing, I did ask just neighbors in Ward 8 about things that are top of mind. One of the things that came up was the movement of a methadone clinic, either to UMC or near UMC. Are you familiar with what I'm talking about?
Yes.
Yes.
Sir.
Can you speak to the success, the status of that relocation effort?
So UMC is still waiting on the external players to reach out and to have a meeting so that we can get all the details, look at the big picture, and to see if we can engage in such an activity. So we're open to hearing about the full breadth of the program.
And who are those external players that you're waiting on?
There was, I can't recall the name right now, but somebody with the last name of Ford.
Okay, fair enough. Do you mind just following up? I would imagine I'm not an at-large member, but we are representing residents across the city. I would imagine it would be top of mind for Chair Henderson. So if you could follow up with us with that information and any way we can support, neighbors are very interested in just the status of that relocation.
Yes, when I was informed that they would like to have a dialogue, I reached out on several occasions, and I'm still waiting for a definitive date and time to meet to hear about the program.
Understood. And I'm going to switch gears yet again. You, in your pre-hearing responses, spoke to the violence prevention work that you're doing. It's my understanding that that was paused for a period of time during the pandemic, but it recently restarted in January of this year or last month. And can you similarly just talk to the status of that program? I would say this is another example where I wasn't totally clear, just given some of the detail, the lack of detail in your response, like what the activities are and how you're actually engaging in this partnership to prevent violence.
So the program should have started, was slated to start in January, on January 19th, and it has not started because a couple of the employees who are part of that program, non-UMC employees, the people are part of the program, they have not cleared our background or health clearance as yet. So we're waiting on.
Is that the Far Southeast Collaborative you're waiting on?
Yes.
And what exactly are the activities that, assuming everything moves forward, you would be engaged in?
Assuming everything moves forward, once the patient comes into our emergency department and is identified as a victim, our triage nurse would tell the program person who is sitting within our hospital that we have a customer, and they take it from there, supporting the person and getting resources out of the hospital if whatever they would need.
And when you say a patient, so they come in for care.
They come in for care, yes, sir.
And they need I'm assuming there's a criteria of sorts that you're determining whether they meet the needs for this additional program.
Once they come in and they're identified as a victim, period, then that's when we do our medical stabilization or whatever we need to do for them medically, then inform this program, and they would talk to the person. It's very confidential. If they need shelter, if they need the police to be involved, they're the liaison. They have that support right now when they're going through this crisis.
And in the absence of this program, what are you all doing to provide that additional support for patients that may need it, if
In the
anything?
absence of that program specifically, we reach out to the sexual assault center that's housed at Washington Hospital Center, if it's sexual assault. For other assaults, I can't say exactly what we do, but I know for sexual assault for sure.
Okay. Thank you for that. If there's
But I
any way
will add that, sir, that we do have case managers and in the ED. And so most likely based on their typical duties, if they need this, there a need for other services out of the hospital as part of their discharge from the ED, they would get some assistance that way. In general, for most patients. So
through the case management work that you're doing.
Yes, sir.
Understood. Understood. And are you paying for this partnership at all?
I am not sure. I don't know. I would have to get back.
No. Okay.
We're not paying for. We're
You're
not
not
paying
paid for it. Got it.
We're not, again, like she said, we have social workers that are even in our records. When a physician is seeing a patient or a nurse, all those are documented. And then social workers and case managers, like she said, they follow through to make sure a patient is not just released out there to danger, because that's one of their criteria, is to discharge the patient to a safe environment.
Yes. And what I'm getting at with my questions between the methadone clinic, between this violence prevention program, is that the care you all are providing, and I know you all know this, but for those that may be watching, the care you're providing is just one component. And these other programs and services provide the continuum of care that is needed for a lot of patients that are coming in, namely in wards 7 and 8. With about a minute left, I do want to circle back to the staffing shortages. And can you just speak to where you are with nurses and what efforts you are taking to fill any gaps in staffing?
In terms of the nursing, like we mentioned before, we are using the agencies to fill the gaps of critical areas. Well, all areas are pretty much critical in our field of work, our line of work. So we're using staffing agency. That's our primary way, besides trying to recruit. But we cannot afford to have the gaps in staffing, so we have to rely on the staffing agency, the nurses who come.
Understood. And you were going to say something, sorry.
I said they come highly vetted. It's, you know, they're screened well before coming. All our nurses have to look the same in terms of, if you're an ICU nurse, whether you belong to UMC on our staff, as compared to an agency nurse, we have to have the same core standard competency levels.
Gotcha. Thank you. That is my time. I look forward to the next round. Thank you.
Thank you, Councilmember Parker. I want to go back to, I have a couple more budgetary related questions. In the pre-hearing responses, you all stated that in FY23, $5 million has gone to unbudgeted legal settlements. Is there more information that you can provide on that?
I could bring you breakdown. As you know, our legal issues are kind of confidential. So because that we responded there from the savings that we realized from the operator. Definitely, we do have challenges with legal settlements every day, and I could provide you that. And I have to get clearance from a general counsel and anybody else, and then I will provide that to you.
Okay, that would be helpful. And just as a warning, my laptop, I don't have the power cord, so it's going to die on me soon. We're trying to get that, but you'll still be able to hear me. You just won't be able to see me for a minute there. As you all know, President Biden has announced at the end of the federal public health emergency. I'm curious how that is going to impact hospital operations as it pertains to COVID-19 in particular, and are there any special concerns that you all might have in terms from a financial standpoint of what you can and cannot seek reimbursement for?
Not at all. No impact at all. We factored all that in all our numbers that we're presenting, whether to the auditors or that we're sending to you guys. They're all factored in. Not at all.
Okay, great. Will this also, in terms of PPE, have an impact on you all? No.
As a matter of fact, we do have abundance of PPEs.
An abundance.
Right now. Believe it or not, I'm hoping maybe I could sell some of them. No, I'm kidding.
Okay. Can you explain how UMC collaborates with the Department of Behavioral Health in terms of psychiatric care that's provided to patients at UMC? How often are you in communication with that agency about this particular service?
Our behavioral health unit, they have a very close, open relationship with members of Department of Behavioral Health. I can't tell you the frequency, but I know at least once a month they collaborate at least, because it's an ongoing process with our patients coming in. We do have a memorandum of understanding with DBH as well for our involuntary patients to provide care for district residents who need care for behavioral health.
Okay, I'm gonna ask more. I'm gonna ask more about that in just a minute, but
Sure.
just for so we're all sort of operating on the same numbers. I have that you all have 33 beds for inpatient psychiatric treatment. Is that accurate?
That is correct.
Okay. How many are currently filled right now?
I could check our census today and get back with you for the census for the BHU department. I know our overall census, but I didn't check our BHU, but I can check that right now.
Okay. Well, if I'm sure someone on your team is probably watching, and they'll shoot you the number.
They'll
So
shoot me. Yes, ma'am. Thank you.
all right. So I'll ask in the in-between, in the pre-hearing questions, you reported that UMC served about 1,229 patients for psychiatric care in 2022, and 61 so far in FY23 to date. And I guess it's hard to tell because FY23 just started. Well, technically,
yes,
we've
started. So
been a couple of months in. But do you feel like that's on trend? The 63 that you've seen thus far is on trend to match what you did in FY22? I guess I'm trying to determine, are you all seeing an increase in psychiatric patients where you may be seeing a decrease in activity in other places within the hospital?
What happens with our psych unit is you could have 10 this month. Next month, you could have the entire 33 bed filled. So the trend, the first quarter trend, when we get to the half of the year, that might be a better trend to use, because on a month to month, it really doesn't move in that direction that way at all.
Okay. Well, so I want to ask a couple of questions then about the process for which an individual can be admitted for inpatient care. Do you reserve under your MOU with DBH, do you reserve a certain number of the beds for involuntary patient admissions versus someone who comes through the emergency room and it's determined that they need care?
No, we do not reserve beds.
Okay. So in the cases where you don't have any space available, what happens?
We have to talk to Psychiatric Institute of Washington, for example, and St. Elizabeth's Hospital.
Okay.
So to see if we could transfer the patient there if we are full.
Okay. I recently met with the Hospital Association. You were there for the meeting. And so I the knowledge of knowing without Providence, it is you all, it is PIW, and it is Washington Hospital Center are the last three places
that will accept involuntary patients.
Correct.
Yes.
So I'm just trying to, I guess, this is more a question for DBH, I guess, later in terms of how many inpatient beds we have across this, how many inpatient and voluntary beds we have across the city, and have we ever reached a cap and what happens there? Or if we all feel like we're in a good place, which I don't think that we do necessarily. Okay. Can you describe the process for how UMC is notified when you are receiving a patient being transported via FD12?
I'm sure I will miss some steps since I don't work on the behavioral health unit, but a global picture is there is a phone call placed from CPEP, for example. That's the Comprehensive Psychiatric Emergency Evaluation Services Program, yes. And so we'll get a phone call. They'll talk about why the patient needs to come. The patient is coming. The patient comes through our ED. There is an evaluation done by the psychiatrist and a case where an intake coordinator, the determination if they're going to be admitted. They reach out to, let me make sure I'm saying this correctly. They reach out to this access line, which is under Department of Behavioral Health, who does tracking for the patient and gives authorization, yes, please go ahead and treat. Then the patient will go up. Once they're stabilized, COVID is negative, they go up to the unit. If they're medically cleared, if they're not medically cleared, if they have some comorbid situation, and it's not purely psychiatric, they will have to go to the medical unit with special care and special referral to the psychiatrist.
Okay.
That's global.
That's helpful, I think, to sort of paint a picture in terms of what we're, when you're dealing with these particular patients. Do you have an average in terms of the length of stay? Obviously, I know it varies, but.
It varies. I would say 5 to 6 days.
5 to 6 days.
Yes, because remember, Chair, it's acute care, stabilized. It's not long-term.
Right.
Like St. E's has a model of long-term as part of their program. Ours is strictly acute, fix, get them nice and ready, back to integrate back to their families and wherever they need to go.
Wait, which place did you say was the long care? I'm sorry.
For example, St. Elizabeth's, part of that has a long-term.
Yes.
Yes.
Okay. Okay.
For chronic mentally ill.
And for the discharge, I guess I'm just trying to drill down just a bit, because I had my hearing last week, several public witnesses who testified around discharge charges when we're dealing with psychiatric patients. In particular, they were talking about PWI or PIW, but I'm curious in terms of UMC as well. What happens when you have an instance where you don't believe the person still needs your level of acute care, but you don't necessarily feel like they are prepared to return home?
So in
like who is doing the care coordination?
Right. So there is a case manager, psychiatric case manager, who collaborates with the core service agencies. For example, there's a place called Community Connections or Pathway to Housing, and there is also a place called MBI that has more a full service next level psych treatment facility. So our workers here would link up with those community service, core service agencies for continuity of care.
Okay.
And ensure that the patient has a discharge, an appointment post-discharge. That's very crucial for us, for the patient to know that your appointment is going to be at X, Y, or Z.
Yep. Is the care coordinator an employee of UMC, or is that?
Yes.
Okay.
Employee of UMC.
How many do you all have? I'm sorry, that's a very specific question, but.
We may have, I'm looking at a list, I think we have about 2.
Okay. Okay, I want to move on to some of the other things that you do. First, follow up from Councilmember Parker's line of questioning around the number of patients that you all see who have diabetes. for clarification, I think in the pre-hearing questions, you weren't saying, were you all saying that 40% of inpatients that you see have diabetes?
Yes, that's what we're saying. It may be, they probably did not necessarily present for diabetes.
Right.
They came for something else, and that's a secondary diagnosis. And so regardless of whether they came presenting with their diabetic situation or not, we still do engage them in some teaching to see what they need at their level.
Okay. Do you have plans to restart your group instruction for the diabetes program?
Our diabetes education person is excited to do that. We want to make sure that we're abiding by all our COVID mandates, restriction. I know that's going to be lifted soon, so I anticipate that should be happening after that.
Okay. I guess I'll follow up at budget time to see if there's been any progress on that front. I just think that's a very staggering number, but I think it also goes to show in terms of, like you said, right, someone might have come to the hospital not for anything diabetes related, but it's, you know, some other thing. But it's important in terms of their treatment plan, right? Like, it's like, okay, this is a very significant part of it as well. And it brings into question around some of the conversations nationally that are being had around insulin and other things within the diabetes programs. DC Health conducted its annual survey related to quality of care at UMC in November of 22. Have you all seen a draft or final copy of their findings?
We have not. We're waiting for the final copy.
Okay, still waiting. All right, so we can follow up with DC Health on that. Okay, let's talk procurement. That was our favorite topic last year. In FY21 and FY22, the council received quite a few retroactive contracts. Ms. Jacobs, can you describe your efforts that you've taken since becoming chairperson of the board to ensure that contracts are being properly executed, including whatever is necessary for council approval?
Yes, thank you, Councilmember Henderson. The board takes a very focused view of contracts. We meet regularly. I meet regularly with the CEO, as well as with the contracts director and the general counsel. There has been additional training that's been put in place to make sure that staff at UMC understand the procurement timeline and how critical it is to make sure that we timely review our contracts inventory so that we don't continue to present the council with retroactive contracts. Dr. Payne Borden, I think, can talk more specifically about some of the training that we've put in place and some of the steps that we've taken. But as she said earlier, it's our goal to certainly minimize and to eliminate sending you retroactive contracts.
Okay, can I ask a clarifying question? Because I don't think that this was the case last year. I think there was a particular period of time where your general counsel was also doing procurement. And are you saying that you now have hired someone separately within that office to handle procurement specifically?
Yeah, we have a vice president of contracting and procurement now. Yes.
Oh, that's new. Okay. All right. Okay, I'm over my time. We'll come back to that. Councilmember Parker.
Thank you. I want to zone in on the closure plan, and of note, there were no details provided. And so I'm just going to walk through a line of questioning. When is the expected date for closure?
So as you're aware, council member, the hospital will remain open until the new hospital, the Cedar Hill Regional Medical Center, opens. And that projected date is the first quarter of calendar year 2025. That's what we know at this point. Of course, you know, their construction, that date could change, but that is the date that is the target at this point in time.
And is there a plan? I know one wasn't provided, but is there a plan that you can speak to around transition?
There's not a specific plan at this point in time. The executive leadership team is working on the details of that plan. We are aware of the regulatory requirements and the notification requirements. And again, all of that will have to be closely coordinated with the information that we receive regarding the opening of the new facility. But I know that the team is working very diligently on providing the board with a draft to review no later than the third quarter of this fiscal year. And upon its review and approval, then we would be able to share the details of that plan with the council.
And so you're going to share with the board third quarter of this fiscal year, the plans for closure transition. I'm going to use the term closure, just to be clear. And so where are you with that? I know there may not be a plan in full, but I would imagine there has to be a skeleton, goals, priorities laid out. And what I'm getting at is just the questions that we've already asked around the level of care that you're providing, the procurement, the contracts. It would seem to me there would need to be some prioritization and planning to how you're going to sunset a lot of that in the very near future.
So let me say that as long as you know, the legislation that governs the hospital, we're required to have an emergency room and the inpatient services that support that. And so as long as the hospital has an open and functioning emergency room, we will have to provide a full complement of care. Now, as we've also said, though, as our activity dwindles, we will tailor how those services are provided to meet the activity level of the patients that we serve. And so that's part of the work that the management team is doing now. They're looking at what our utilization rates are. They're looking at what our regulatory requirements are in terms of the notices that we have to give. But I guess when you say a specific plan, are you asking me now about specific dates?
Less dates, but more so the plan. I would imagine there would need to be programs that would need to be sunsetted. There would be terms that would be established with contracts. There would need to be a transition. Everything that would go into the closure plan that you are developing. I'm trying to get a sense of where you are in that process. So it's very clear you gave a very concrete date or a period of time that third quarter fiscal year, the plan will be delivered to the board. I was just trying to get a sense of where you were with planning leading up to that.
Chair Jacobs, I could answer.
Yeah, so go ahead, Lily.
Okay. Thank you again for that question. We have, as a team, we have started identifying the steps that need to go into the plan. First of all, we met, and we have met like a few times, talking about staffing part of it, because as it draws closer, people are leaving. So we're making plans. What is it we have to do to make sure that we retain staff? And that is a plan. And I'm going to build a budget around it to bring to the CTCFO to say, this is what is going to need for us to sustain. And then at that point, then we know how are we going to do a communication plan to tell our employees and say, we want you here, don't go, don't run, don't do this. So we are meeting, we're identifying the step by step.
I have full confidence that you all are meeting and talking. I just wanted to get a sense of where you all were, in part for exactly what you're saying, that, we want to make sure we're providing a continuity of care for residents, and that plan and transition and coordination is just going to be really important for that. So you were saying?
Yes, I would say, because we have discussed, who do we need? Project manager, what? So those things are, it starts with a conversation. It starts with the team being on the same page, and we are skeletally putting things down, and then we will flush it out to bring to the board. So definitely it is one that is already on our radar and agenda, and we are going through, because the medical record piece of it, we need. Where are we going to transfer the record? So the conversations are there. The skeletons are coming together of what things, identification is key, because when you finish identifying, and from my office, what do I need to do? The closing, where do we need to do in the regulatory arena? Who needs to do what? How do we transfer back the assets? How do we engage the city?
That's exactly right.
So we are all those jotting them down. Then we're gonna just, after we finish, we just put them all together and then take the draft to the board. So right now, there's no particular part of it that is done. All of the conversations are happening stage by stage, because not everybody's involved in all of the stages, but the CEO and myself, and we are working on it, and we will get you, keep you posted maybe from where we are, so that you'll be part of it. You guys will be part of it, but not give you the detail before the board approves anything.
Of course. No, I appreciate that. It was more so to get a sense of just where, if that was the finish line, where we were in the process. Connected to that.
May I interrupt for a second, Councilmember Parker, just to add to painting this picture. So a very concrete thing that we did in the last year was it naturally unfolded where we had one unit as a medical surgical unit and one was a telemetry unit, but because the volumes weren't supporting both units, we combined the two units. So that's a natural progression.
Got it. So, and that speaks to those efficiencies, I'm assuming, that you were referencing earlier. So thank you for that. Connected to that, and looking at the budget, can you just speak to what, and I know we aren't there yet, perhaps, but how you're anticipating budgeting through this transition and the closure plan? And so what I'm hearing you say through your testimony today is that we have a reduction in the dish, but a reduction in activity. There are staffing shortages, and so that you are relying on contract support, among other things, and needing to be innovative and finding efficiencies. You have programs that are both community-based, but that are on site, while all the while you're having to transition and close, essentially. And so what does that look like as you all are mapping out budgets, thinking through procurements for the future?
Of course, my role is a constant reforecasting, because we have to keep our pulse on it. You know, I don't have the privilege of waiting a couple months to then see what is going on. So we are reforecasting as those things change. Just like yesterday, they're making a move of one unit to another unit. It comes back to my number. What would that be now? What is the impact? What is the staffing level? You know, everybody's looking at restructuring based on where things are moving. So the budgeting is constant. The reforecasting for us is constant. Where we are reforecasting and say, okay, now what is this impact? Where will I be? What does it look like? You know, if this happens, so then, and we go to the board and tell them, this is what's happening, this is how it's going to happen, and making sure that by the end of the year, so as we reforecast, then we resize. Then I communicate to the CEO and said, you supplies need to go this direction because of these activities. You know, overtime needs to go this direction because this is what I see the activity going. Even contract labor, as we say, we're giving them the opportunity to use contract labor. We still say, this is contract labor, this is your activity level, it doesn't support this. So constant monitoring and constant management. As a matter of fact, we meet every Thursday. We call it initiative. We call it initiative meeting every Thursday for 2 hours.
And those meetings must be productive since you have a surplus, right?
Well, for real, it really does, because that's where we all hold each other accountable. Everybody's open. That's the excitement of the new UMC, running UMC. Everybody's communicating. Everybody's offering ideas of what needs to be cut off, what the waste. We are just
and so making sure I'm tracking. You all are meeting weekly, and is that reforecasting happening weekly?
Yes, my reforecast happens almost daily. Really, it's like my cash.
Got it.
I don't have a boatload of cash, so my cash is a daily thing that my shop does, and my reforecasting is daily. to just looking at it quickly, just putting, okay, this is not what happened based on this meeting that I came from. What would that leave me? So that's where we are touching, making sure that our hands on it.
And one more follow-up there. Can you describe, if they exist, areas where you've had to draw down services to patients? In other words, in this reforecast process, have you had to cut programs, services, care, perhaps because it's too costly or for some other reason?
Not at all. As the chair said earlier, Director Jacob said earlier, we must give care. ED is there. We are full service. Every complement that we need must receive. However, what we're doing is, if we have activities that, we have them open for 5 days, but we don't see anybody, but maybe only Monday, we see only 2 people. And for 4 days, we don't see, we look at it to see how do we then restructure that, never to affect the patient, never to make the patient feel like, oh, they don't have what they used to have. We must continue to look at it to see, oh, this is a service. Nobody's coming to this service from Monday to Friday. We have no activity. Therefore, for that reason, they look into it and making sure if it is a needed service that must be, because in our business, there are things we call loss leaders. They don't have to be necessary, but they must be there because you never know when we need it, right? So if it's a service that must have to have, it's gonna be there. If nobody is coming, all we could do is maybe change the hours or how many times we're open for it to match the activity.
Gotcha. That makes sense. Thank you for that. And then I'm going to end with a more softball question. And just like, what support, generally speaking, do you all need through this closure process? And maybe Ms. Jacobs or anybody can take that. What support is needed?
Thank you for that. I think that as we formulate the plans more specifically, we'll be able to better answer that question. So I would just like to say we would like to keep that line of communication open. Certainly, there's a potential that as we look to closure, we may need to have different kinds of contractual support, different kinds of services that we may need to rely upon. But we will know that better once we have the detailed planning. And so we'll definitely come back to you. And if there are additional needs that the council can support us in, or particularly the Committee on Health, we will definitely communicate that.
Yeah, I'm sure I speak for all of us, and we want to support as necessary to continue the care for residents that you're supporting, and that there isn't a gap. And so that is top of mind for me, that as we're going through this process, that is not felt by residents. And so thank you for your time and answering my questions. And I'm going to yield it back over to you, Chair Henderson.
Thank you, Councilmember Parker. It's always fun when there are other people at these hearings because bring up some questions and things like that. Do you need another round? Because I don't, but. They satisfied all of my questions. I would ask though to the UMC team if you could follow up on those areas. We have a list. We wrote down all of the things, and so We'll go for it at the end.
Thank you.
Thank you. Okay, we're almost done. So a few more questions. Let's go back to procurement. So you all said you now have a VP of procurement and contracting, which is a great improvement. I want to ask, so in the November 22 board minutes, you guys know I read the minutes, UMC, Ms. Chakuma, you reported that Mazars purchased PPE that did not meet hospital grade standards, leading to $2 million in waste and increased cost for replacement. So I have a few questions on this. First, what verification standards have we now put in place? Or rather, go back. What verifications for PPE did you have in place at the time? And what standards have you put in place now for future purposes?
Thank you for that question. And now that I know that you read it like I didn't know, I know you always read them. As you know, COVID hit everybody. And even the very PPEs were not even anywhere to be found. So every corner everybody was selling PPE. And we were so flexible to make sure we give the hospital what they needed. So we approved for them to purchase. And at the time, they purchased some that were not standard, really, that did not meet the real standard. Again, it's primary for us to give the best quality care. And this hospital, I've been here a long time, they do give good quality care. So those did not meet standard. There were a lot that were purchased within that time frame of surge of COVID that did not meet care. So they didn't use them. So that surplus I told you could have been 4 million if those were good. So that's what we did. We had the opportunity. We did the inventory. We went through it detail. And of course, our CEO, she's a big part of it to say that these are not standard. They cannot be used here. So for that reason, they were write-offs. We wrote them off from our inventory. Now, what have we done? We have a process where purchases are authorized. Suppliers are no longer everybody put what you want. As you see, we're looking for efficiencies to find money. So we are aligning things with activity, right? So we have a level where a director will review it. Now we have a level where, the CEO have to touch it, to see it, to approve it before anybody can purchase. So we have put so many levels of approval. And of course, the VPs we have now are owning it. We're running the place. They feel empowered and they're running it. And for our expense meeting every week, they're all being held accountable and they are really looking into it. So we're not going to have that waste. And our VP of procurement, of course, he's now big time on that, making sure he went through every room in the hospital to see every supply we have. And our CIO also putting bar level systems in place. A lot of things have been brought in to make sure that we don't just waste and overuse or overpurchase.
So what did you all do with the PPE that could not be used at the hospital?
Unfortunately, they are still there. Are you a buyer? No.
Did you say, am I
buying? They are. We still have them. We still have them and trying to determine. As a matter of fact, I reached out to the city, trying to reach out to the city for us to procurement. They're trying to reach out to the city to see what do we need to do? Do we donate them or what? Because remember, the city gives us money. So we want to make sure before we dispose of it.
Because I can't see DC Health being like, yeah, we'll buy it off of you ourselves. But, I think though, there are probably some nonprofit organizations or others within the city who don't need hospital grade, but still need PPE. And this could be a way for them to have access to that.
Yes, so we are looking into that to get approval because, we are prudent stewards. Where we get $15 million from the district. So before we dispose of anything, the district makes a decision for us. It helps us work with us to get that done. So we're working on that.
Okay. Do you know by chance what was the $2 million spent by Mazars on that? Was it from the local subsidy? Was it from federal? Was it from grant? I'm not sure if you would know the source of the spend for that.
When we spend, we don't particularly allocate it that way. The only time that we had to make sure of where we spent from was during COVID. We were getting those federal funds. So we needed to make sure because we had to send in detail of what qualified to be used for those. So, but those we didn't specify. It was all covered in the amounts that were available for us to use. And then the wastes were not included for this federal. So that was really from our money that we could have. So we don't make it local fund. We don't call ours local fund.
Okay.
Federal. Yeah.
Okay. Let's talk a little bit about security. I know that many hospitals, not just in the city, but across the country, have been experiencing some instances of violence, particularly in emergency rooms or in parking lots. Has UMC experienced this? And I think at a time you all were contracting with some private security, and there was some increased costs that's related to overtime. Have we gotten a handle on that? I don't know who wants to take this question.
On the overtime piece, I could speak, but the CEO can take the other piece. Definitely, security is paramount for us because, it increases our insurance. So we pay attention to it because so we do still have those contracts to have the security coverage. Even though our VP of support services is also working on some other alternatives, because that's one of the savings that he has looked at, that getting more security financially stable place for the hospital to continue to have the security that we need without worrying about the finances. So he still has that going on. We still have that big contract that's out there, but he has other alternatives that he's looking in to see how to stabilize us with our security needs. The vacancies also are being filled. That's what he reported, that he's also making more headways with his vacancies. So eventually he might win us off of the heavy duty contracts. So that's where we are now. That's one of his initiatives also, that he's going to be hiring all these vacancies because they're having the traction for people to come. For some reason, I'm happy that they are making that move. Jackie, you have anything to add to it?
Yeah, Dr. Payne Warden.
Yes, I just want to add that our VP of Support Services, he does attend regular DC Hospital Association Emergency Management Committee meetings. And he's also part of the DC Hospital Security Directors Committee. And I know recently in the fall, they did some training regarding active shooter. So he comes back with, new knowledge or expanded knowledge. So we're definitely connected and very conscious of safety and security of our staff and patients.
Okay. I think give me a minute. I think these are all the questions that I have. We do have some follow-ups, obviously, but if you just give me a moment to confer with staff. Okay, so obviously we'll see you in a couple of months for the budget, but this is what I have on my list in terms of follow-ups. So an update on the process status of filling the board vacancy. We have Councilmember Parker asked for a breakdown of the decrease in the dish payment and which services are affected. More details on the metrics for success on the diabetes program, besides the number of insulin shots. More information on a potential methadone clinic being moved to UMC, and including the names of the external partners. And then more information in terms of how patients are referred who are victims of victims of assault besides sexual assaults. Councilmember Parker, was there anything else? I think that was an exhaustive list.
That was great. That covers it.
Okay. Okay. Is there anything else, Dr. Warden-Payne, you wanted to mention?
I wanted to give you the answer for the BHU census today.
Oh, yes.
It's 17, and of the 17, we have 9 involuntary patients.
Okay. 9 involuntary.
And this is just a picture in time because it could change at any minute.
Great. I appreciate you following up on that front. Okay. Hang on. I have some things I'm supposed to say to close this out. So let me just find that part. Okay, so this concludes our hearing today for United Medical Center. Thank you, Ms. Jacobs, Dr. Borden-Payne and Ms. Jakuma for your testimony and for making yourselves available to answer all of the questions that we've had. And also, for the record, Ms. Jacobs, thank you so much for the periodic meetings that we've had over the past, I don't know how long you've been board chair. I think it's been like a year at this point, maybe,
Yes.
over the past year or so, to discuss what's happening with the hospital and to make sure that the council stays informed of the activities and the work that you all are doing. For anyone who was unable to testify and speak at today's hearing, we will be accepting public witness testimony until February 23rd at 5 p.m. You may submit written testimony statements to Ashley Strange at astrange@dccouncil.gov, or you may leave us a voicemail at 202-430-6046. If you leave a voicemail, please remember to speak slowly and to spell your name for the record. And the next hearing for the Committee on Health will begin at 2 p.m. today, where we will be speaking to the government witnesses for the Department of Behavioral Health. But with no further business at this time, the time is 11:11 and this hearing is adjourned. Thank you all. Have a
Thank
good
you.
rest of your day.
You too.
You do the same.